Hi students, hope you're all doing good. In this video, we are going to discuss about cardiac disorders in pregnancy. Okay, I have made it very simple, like I am going to give you only the hint points. The video may be longer, but if you understand it better, then it will be helpful for you, right? Cardiac disease in pregnancy. See, first let us discuss the physiological changes that are going to happen in the cardiovascular system as well as the hematological system. Okay, then only you will be understanding how much implications of these physiological changes will have upon pregnancy. Okay, so physiological changes. Okay, so the first point is, we know the blood volume as a whole increases by 50% in pregnancy, and remember the stroke volume is also going to increase, okay, and this starts increasing by 20 weeks, and the heart rate also increases, and this increases by 15 to 20 beats per minute. Okay, and the next point is cardiac output. So what is cardiac output? It is stroke volume into heart rate. Okay, so cardiac output is stroke volume into heart rate. So if you see this also increases by 50%, and remember this starts increasing by 5 weeks, and the maximum increase in cardiac output is seen around 30 weeks of gestational age. Clear? Okay. And the next point is, you know that the systemic vascular resistance is going to decrease. Why? Because of the hormone progesterone. So progesterone is going to cause vasodilation. So that is going to cause reduction in BP. Okay. So the resistance is also going to reduce. Okay. And next point is pulmonary resistance, okay, is going to increase, and there is an increased preload and reduced afterload in the heart. Okay, and also pregnancy is a state of hypercoagulability. Right? So all these points will help you while we are discussing the topic. Okay. Now, see, these cardiovascular changes are not going to happen only during pregnancy, but it is also going to change during labor and puerperium. Okay. So concept of that changes is also very important. Okay. So if you take pregnancy, labor and puerperium, we are going to discuss about the cardiac output, the stroke volume, the heart rate, blood pressure and systemic vascular resistance. Okay. So, if you see the cardiac output, it increases by 50% in pregnancy, around 50%, whereas during labor this is going to still increase. Okay, if you take it increases around 15% in first stage itself, and during second stage this increases again to 15%. Okay, and during puerperium it increases up to 60 to 80%. Okay, especially in the immediate puerperium, that is in the first hour after delivery. Clear? And this reduces over the next 6 months. Okay, and comes to normal levels. Clear? Next we will see the stroke volume. So if you take stroke volume is going to increase during pregnancy and labor, and it reduces in puerperium. Clear? And if you take the heart rate, as I told you, heart rate is going to increase during labor as well as pregnancy, and it is going to normalize in the puerperium period, and this usually happens within 2 weeks. Clear? Right? And the next point is about the blood pressure. Okay. So, if we take BP, it is going to reduce, okay, initially in the first and second trimester, and after second trimester there is definitely going to be a increase. Okay. That is mostly in the third trimester an elevation in BP is clear. And if you take during labor, definitely the BP will increase, and during puerperium initially there is a fall. Okay. And then what happens means it increases between days 3 to 7. Okay. And then it will reach the pre-pregnancy values. Okay. That is the BP normalizes after 6 weeks of delivery. Clear? Right. And the next one is systemic vascular resistance. As I have told you, systemic vascular resistance during pregnancy is going to reduce, and this is going to increase during your labor, and during puerperium if you take, it is going to increase first, okay, by 30%, okay. Then this is going to normalize after 2 weeks of delivery. Clear? Remember, jugular venous pressure and left ventricular ejection fraction are going to remain in normal levels in pregnancy. Clear? So these are the changes that are going to happen physiologically during pregnancy, labor as well as in the puerperium. If due to any cause the woman is not able to adapt to these physiological changes, then there is a high risk of cardiac failure during that time. Clear? So from this table we can make out the risk of cardiac failure is maximum during, when is the maximum output is happening? In the puerperium, that is in the first hour. Okay. So, the risk of cardiac failure is maximum in the immediate puerperium period. Okay. And then it increases during the second stage of labor. Followed by the first stage. Okay. And then, yes, it is around 30 weeks of pregnancy, there is more risk for cardiac failure. Clear? Yes. See, we will see the heart disease in pregnancy now. Okay, we will discuss about the heart disease in pregnancy now. So, heart disease in pregnancy. Okay, so this can be of various types. Number 1, it can be congenital heart disease. See, nowadays infants born with congenital heart diseases are also able to reach up to their reproductive age and carry out their pregnancy also due to the various improvements in medical and surgical management in congenital heart disease. Okay, and the second one is acquired heart disease, especially rheumatic heart disease, and then there can be chances of ischemic heart disease, or there can be cardiac rhythm abnormalities, or peripartum cardiomyopathy can also occur. Okay. Now, among this, the most commonly seen lesions in pregnancy is acquired heart disease. Okay. Congenital heart diseases are the second most common cause of heart disease in pregnancy. Okay. So, we will discuss congenital heart disease first. See, congenital heart diseases in pregnancy can be classified as cyanotic or acyanotic lesions. Okay. So, if we take cyanotic lesions, okay, that is those lesions having a right to left shunt, and we have acyanotic lesions that is having a left to right shunt. Okay. So, the lesions include Fallet's tetralogy and Eisenmenger syndrome in case of cyanotic heart disease, and in acyanotic heart diseases it is your atrial septal defect, ventricular septal defect, patent ductus arteriosus and mitral valve prolapse. Clear? Okay. Now among this, okay, remember the most common congenital heart diseases, yes, atrial septal defect. Okay, so it is atrial septal defect. Clear? And then the most common cyanotic congenital heart disease means it is, yes, tetralogy of Fallot. Okay, and remember, even then Fallott's tetralogy is more common. The highest risk of mortality is seen with Eisenmenger syndrome. Okay, so Eisenmenger syndrome carries a high mortality rate. Clear? Next we will see the effects in pregnancy. Okay, so effect of congenital heart disease in pregnancy. So if we see the effects in pregnancy, for the mother, there are risks like arrhythmia, heart failure and thromboembolism. Okay, and also she is prone for obstetrical complications like preeclampsia or PPH. Okay, delivery also there can be a need of cesarean section, or delivery also there can be need of cesarean section or instrumental vaginal delivery. Okay. Next we will see the fetal effects. Okay. Fetal effects include miscarriage. There can be chance of preterm labor or fetal growth restriction, or even chances of IUD are increased, and there can be also chances of congenital heart disease in baby. Okay, if you see this itself carries an incidence around 9 to 14%. Clear? Right. Now we will see what we are going to do for the screening for congenital heart disease. Okay. See, that's why screening of the newborn itself is important. Okay. And then you have to do a pre-pregnancy cardiac assessment. Okay. Then during pregnancy, you have to take history. Okay, history taking is very important. You have to know about the symptoms, any aggravating comorbidities if present or not. Okay, then don't forget to ask about the history of childhood heart disease and any surgeries done for that. Okay, and also history of heart disease in family. Okay, all these histories should be included. Clear? And then during examination, we have to check for the pallor, cyanosis, any engorged neck veins are present or not. Then about the pulse, if tachycardia is present other than the physiological tachycardia, or if there are any regular pulse, irregular pulse beat, or if there is hypertension or hypotension associated with the complication. Okay. See, while examining you have to keep certain points in mind. Okay, the normal physiological changes. Okay, so here we know the heart is going to rotate upwards and outwards, right? Okay, because the gravid uterus is going to push up the diaphragm, right? And next one, normally in the ECG, so because of this, where you can locate the apex beat, it is located at the fourth intercostal space, 2.5 centimeter lateral to the mid-clavicular line. Clear? And then if you see the ECG, normally there is going to be a left axis deviation. Okay? And also, if you see in the chest X-ray, you have to, and when you check the chest X-ray, there can be signs of cardiomegaly, and a minimal amount of pericardial effusion is also normal in pregnancy. Okay? So, minimal pericardial effusion. Okay? So, this is also seen in pregnancy normally. Clear? And then, regarding the heart sounds, we have sound S1 to be loud and split. Okay? And sound S2 is heard normally, and there can be chances where you can hear S3. If you hear S3 also, that is also normal. Clear? And regarding murmurs in pregnancy, what kind of murmurs you can hear? Yes, you can hear a continuous mammary murmur, right? Then diastolic murmur anytime is normal in pregnancy. And remember, if you are able to hear a systolic murmur, that is ejection systolic murmur, and if the grade is more than 3, then it is abnormal. Okay, so up to 3 it is normal. So otherwise I will give you like this. Okay, so less than or equal to 3 you will be able to hear normally. Okay, so these are normally heard. Clear? So these are the normal findings we will be seeing in pregnancy. Okay. Now other than doing examination, investigations like ECG, chest X-ray or 2D echo can also be ordered, right? Now we will see the prognosis. See, prognosis in the mother depends upon number 1, what is the nature of the lesion? Okay, what is her functional capacity? Then, is there any other risk factors? Or if there is a need for corrective surgery. Clear? See, there is a classification called NIHA classification that will be categorizing the people according to their risk factors. Okay. So, if we take NIHA classification, that is New York Heart Association classification. Okay. We will be categorizing people into 4 grades. Okay. We have 4 grades here. So, grade 1 is where there is no functional limitation of activity. Okay. No functional limitation of activity and symptoms with extraordinary physical work the same. Okay. And if you take grade 2, we have mild limitation of physical activity. Okay. And symptoms are seen even with ordinary work. Okay. Symptoms are seen with even ordinary physical work. Clear? And then grade 3, we have mild limitation of physical activity. Okay, that means symptoms are seen even with less than ordinary physical work. Okay. In grade 4, there is severe limitation in physical activity and symptoms are seen even at rest. Okay. So, symptoms are seen at rest. Clear? Right. So, among these grades, grade 1 is associated with least morbidity, whereas grade 4 is associated with increased risk of morbidity and mortality, right? Now, we will see some heart diseases in which pregnancy is contraindicated, okay? So, contraindications for pregnancy. So, this is mostly seen in pulmonary arterial hypertension. It is more importantly contraindicated in secondary pulmonary arterial hypertension than primary pulmonary arterial hypertension. Okay. So, which is the secondary pulmonary arterial hypertension condition? Yes, it is Eisenmenger syndrome. Okay. So, this is Eisenmenger syndrome. Already we have seen this is an absolute contraindication to pregnancy because the risk of death, okay, it is going to be as high as 30 to 50% in this case. Clear? And the next contraindication is severe systemic ventricular dysfunction, okay, as well as when there is left ventricular obstruction. Clear? So, this is one of the most common cause of heart disease in pregnancy. Okay. So, it constitutes about 88.5% of cardiac disease in pregnancy. Clear? And then among rheumatic heart disease, mitral stenosis, okay, is the most common rheumatic heart disease, okay, and it is the most common cause of mortality also, okay, cause of mortality also than the congenital heart diseases. Clear? And also remember the symptoms of cardiac disease in pregnancy including rheumatic heart disease. Okay. Symptoms include there will be progressive dyspnea or orthopnea and there can be nocturnal cough, hemoptysis, syncope, there can be chest pain or fatigue, exercise intolerance. Okay. If you see, most of these symptoms are going to overlap with normal pregnancy. Okay. And some signs you can see include cyanosis, clubbing, and there can be persistent neck vein engorgement. The scoring system for acquired heart disease is Carpreg. Okay. Just the name is enough. Clear? Now we will see the management. First, we have to give preconceptional counseling, okay, if there is a woman with cardiac heart disease. See, this should include a teamwork. Okay, so the counseling should be given by an obstetrician as well as a cardiologist. Okay, and remember, you have to include the patient as well as a care provider in the discussion. Okay. So, what we are going to do in the preconceptional counseling? What are our main goals? Okay, so goals include, we should review and individualize the maternal and fetal risk of pregnancy. Okay, and because there are some conditions in which pregnancy is contraindicated. Okay, so contraindications of pregnancy. First one is pulmonary arterial hypertension, whether it is a primary or secondary. Okay, but remember, in secondary pulmonary arterial hypertension, the pregnancy is absolutely contraindicated when compared to the primary arterial hypertension. Okay, so which is the secondary pulmonary arterial hypertension? Yes, it is the Eisenmenger syndrome, right? So it is Eisenmenger syndrome where pregnancy is absolutely contraindicated, because if you take the risk of mortality, okay, in Eisenmenger syndrome is between 30 to 50%. Clear? And then it is also contraindicated in severe systemic ventricular dysfunction. Okay, as well as when there is a severe left ventricular obstruction. So, severe left ventricular obstruction. Okay, it is also contraindicated in severe mitral stenosis. Okay, and then it is also contraindicated in severe asymptomatic aortic stenosis. Also in severe aortic dilation. Okay, then in Marfan's syndrome. Okay, where the aortic dilation is more than 4 centimeters. Okay, and also in Ehlers-Danlos syndrome. And severe coarctation of aorta. Okay, and also when there is a history of pericardium cardiomyopathy with residual heart disease. Also in NIHA class 3 and class 4. Okay. So, when you do risk stratification using NIHA scoring, remember, so if you are doing risk classification using NIHA score, remember that if they are going to fall under NIHA 1 and 2, then you can offer them routine antenatal care and you can plan their delivery at term. Clear? Suppose if they are falling under NIHA class 3 and class 4, okay, then if they are seen in the first trimester, okay, so if they are seen in the first trimester, you have to advise them medical termination of pregnancy. Okay, if they are seen in the second or third trimester, you have to ideally hospitalize them. Clear? So, these are the general rules of doing classification in the preconceptional visit or in the first antenatal visit. Clear? And other than that, you have to assess their baseline cardiac function by doing ECG, echo, and sometimes exercise stress testing can also be done. Okay. So, this is an important tool to assess the excess capacity for development of arrhythmias. Okay. And sometimes additional investigations like MRI or CT may also be needed. Clear? And remember, if she is already known case of cardiac heart disease, her medications should be reviewed before pregnancy, because she may be on drugs like angiotensin receptor blockers, angiotensin converting enzymes inhibitors or statins. Okay, so everything should be reviewed, and if there is a need of surgery for her condition, okay, then it should be ideally planned before pregnancy itself. Clear? And also remember, we have to do this risk classification in the antenatal visit first time or during preconceptional period itself, because this is the period when most of the newly diagnosed conditions will be presenting. Okay, so even if there is a pre-existing lesion, it wouldn't have been identified earlier. Okay, so screening is very important. Clear? And regarding cardiac surgery, the most commonly done cardiac surgery during pregnancy is balloon mitral valvoplasty. Okay. It is otherwise known as percutaneous balloon mitral valvoplasty. Okay. So this thing can be reported. There can be a need of the surgery in NIHA grade 3 or grade 4, and also suppose surgery is not done before conception, means we can also do it in the late second trimester or otherwise early third trimester. Okay. With this, most of the cases become asymptomatic. And also remember, however, there is risk of radiation, and the procedure has to be done only in selected patients where there is absolute indication. Clear? Next, we will see about the antenatal care. Patients with symptomatic valvular disease should be seen at least monthly once till 36 weeks, and after that at least weekly once till delivery. Clear? So, suppose there is a symptomatic and significant valvular lesion. Remember, they should be seen monthly till 36 weeks and followed this every weekly till delivery. And they should be advised for salt restriction in their diet and to avoid smoking or alcohol. And we have to supplement them with nutritional supplements. At pregnancy, we shouldn't increase the risk factor for heart failure, especially the infections. Okay, so keep a check on infections like asymptomatic bacteriuria or urinary tract infections, and other conditions that can lead to heart failure like preeclampsia, okay, or obesity or anemia. Okay, so we have to advise them to keep a check on their weight also. Clear? And remember, at each ANC visit, okay, every ANC visit, the patient has to be reclassified again according to the symptoms. Clear? And it should be a joint obstetric and cardiology review. Okay? And remember, if they belong to class 1 or 2, we can hospitalize them around 37 weeks. Okay? Suppose if they belong to class 3 or 4, then immediate hospitalization may be needed. Okay? Ideally, termination of pregnancy should be advised. Okay? So, especially in which of the conditions you will advise termination of pregnancy? It should be advised in primary pulmonary hypertension, okay, and Eisenmenger syndrome, and then pulmonary vaso-occlusive disease, and also in some conditions of cyanotic heart disease. Okay. Suppose if the patient is presenting with proteinuria during examination, it can be due to preeclampsia or cardiac failure or even due to urinary tract infection. Okay. So, that should be individualized. And remember, if the patient wants to go for dental extraction, okay, any dental problems, remember dental extraction can be preferred over root canal treatment, okay, and dental extraction should be planned under antibiotic cover. And pneumococcal and influenza vaccines are recommended. Okay. Now, we will see the fetal surveillance. We have to do a fetal baseline scan, and importantly, we know at 11 to 13 weeks we will be doing a NT scan, and 20 weeks we will be doing a anomaly scan, and remember, additionally at 24 weeks you may offer them a fetal echo also. Clear? And then you have to monitor the growth properly, because the fetus can have FCR in case of cardiac disease complicating pregnancy. Starting from 32 weeks, NST and biophysiological profile should be done, ideally at once a week or at least once in 2 weeks, okay, depending upon the clinical status. Clear? Right. Now, we will see the management during labor. See, during labor, there is an increase in heart rate, blood pressure, and also oxygen consumption. Okay. And after delivery, okay, after delivery what is going to happen is, there is increase in the cardiac output, because an additional 500 ml of blood. And remember, there is an increase in cardiac output, one due to uterine contraction, okay, and there is an increased amount of blood, that is about 500 ml of blood will be entering the mother circulation due to the blood that is entering from the extravascular space, okay, and also due to increased venous return from inferior vena cava. Clear? And then usually the physiological changes revert back to normal in 2 to 3 weeks. In some cases, they can persist up to 12 weeks also. Okay. And remember, the risk of cardiovascular collapse is more during labor and early postpartum period. Next, we will see about labor, that is induction of labor. Okay. Sometimes we can see some complications with induction of labor. The complications include, there is prolonged induction interval and more chances of infection. Then there can be increased chances of cesarean section, and there can be increased chances of fluid overload. Okay. So, while doing induction, you have to keep in mind the following points. Okay. So, usually oxytocin infusion is the method of choice for induction of labor. Okay. And because PGU2 gel, because remember PGE2 gel has more profound effect on hypertension when compared to misoprostol. Okay. And then early amniotomy is not advisable. Okay. We will be using prophylactic antibiotic. Okay. Remember to ensure fluid balance. Okay. You have to keep the patient in semi-recumbent position. Okay. You have to discuss about the regional or epidural anesthesia. Okay. And this discussion has to be done with the senior anesthetist available. And then to cut short the second stage of labor, we can even try instrumental delivery using forceps or vacuum. Okay. So, the antibiotic given in labor is when there is a rheumatic heart disease, we will be giving ampicillin or amoxicillin 2 gram orally, or we can have an option of administering vancomycin 1 gram IV over 1 to 2 hours if the patient is in active labor. Clear? And then if the patient has a prosthetic valve already, okay, you can have ampicillin 2 grams IV or gentamicin 1.5 milligram per kilogram, okay, up to a maximum dose of 120 milligram during active labor. Clear? Yes. And regarding cesarean section, it is indicated only for obstetric causes. Okay. And there is an increased risk of hemorrhage, thrombosis, infection, and also anesthesia risk, okay, in patients with cardiac disease. And remember, while managing the third stage of labor, we have to give oxytocin 10 units IM within 1 minute of delivery of baby. Okay. So, ideally it is a part of active management of third stage of labor. Why I am telling this is, you should avoid methylergometrin, okay, because it can cause severe vasoconstriction and congestive heart failure in patients with valvular heart disease. Clear? And if needed, we can use PGF2 alpha or misoprostol for controlling PPH. And suppose if the bleeding is prolonged and there is a need of blood transfusion, we can offer them with PRBC. Okay. Suppose if the patient is already on anticoagulants, then you have to provide them with FFP also. Okay. And also remember, during puerperium, you have to give meticulous care because a lot of changes are going to happen in the puerperium also. Okay. Number 1, there is increased venous return to the heart. Okay, because the uterus has emptied its most of the blood into the systemic circulation, and there is decreased venocaval compression. Okay, the compression on inferior vena cava is released now, and there is mobilization of fluid from limb and lower body. Okay, clear? So, in these patients, important complications to be looked over in puerperium period are PPH, infection, anemia and thromboembolism. And also remember to offer them sterilization procedure, okay, if they are looking for a permanent method of contraception. Otherwise, other methods of contraception like barrier methods, IUCDs, especially the levonorgestrel IUCD, okay, these are considered the safe and effective options. We need to discuss one important management, that is anticoagulant management in pregnancy. Okay. See, at 4 to 6 weeks of pregnancy, you have to change. If they are already taking warfarin, means you have to change them to heparin. Clear? And again in the second trimester, you have to change them to warfarin again, starting from 12 weeks, and you have to maintain a target INR range between 2.5 to 3. Clear? And this should be done initially daily. If it is normal, you can change to weekly or monthly. Okay, we are changing this because there are more chances of warfarin embryopathy if they are taking it in the early developmental stages. Clear? And again, at 36 weeks, what we'll do is, patient should be admitted, admit the patient. Okay, now patient is on warfarin, right? So, now again stop the warfarin and start her again on heparin. Okay. Suppose if delivery is planned means, can I do? Suppose if delivery is planned means, in case of normal vaginal delivery, you have to stop heparin before 6 hours. Okay. And in case of cesarean section, you have to stop heparin before 12 hours. Clear? And you have to restart it immediately, but the restarting time should be 4 to 6 hours after delivery. Okay. So, this heparin will be continued at least for 3 days, and then it will be changed to warfarin once again. Clear? Yes. See, there are antidotes. For heparin, which is the antidote? It is the protamine sulfate, right? And for warfarin, we can use vitamin K. Okay. Suppose if there is a need for urgent delivery like preterm labor or any other obstetric indications we are taking cesarean section means, ideally fresh frozen plasma should be given prior to the delivery. Okay. Now, we will see the various options of anticoagulants in pregnancy by differentiating between them. Okay. So, if we take anticoagulants in pregnancy, we have warfarin, unfractionated heparin and low molecular weight heparin. Okay. In that, First we will see the risk of thromboembolism. Okay, the risk of thromboembolism is least with warfarin, whereas it is increased in unfractionated heparin and low molecular weight heparin. Clear? And the second point is whether the drug crosses the placenta or not. Okay, in that if you take, yes, it is the warfarin that is going to cross placenta. That's why I told we are going to change the drug during the early stages of pregnancy. Okay, when the congenital malformations risk are more. Okay, and here they are not going to cross. Heparin is not going to cross. Clear? And the next point you have to keep in mind is about their teratogenic effects. Yes, I have already answered this. Teratogenic effects are seen with warfarin. Okay, and these are not going to cross the placenta, so no teratogenic effect. And the next one is whether there is a chance of late fetal death. Yes, it is also seen with warfarin. Okay, whereas it is not seen with the low molecular weight heparin or a unfractionated heparin. And then we have the chance of loss of bone mineral density in the mother, and this is seen with unfractionated heparin more, but it is not seen with warfarin or low molecular weight heparin. Clear? And then there is a chance of thrombocytopenia. Yes, this risk is also seen with unfractionated heparin. Okay, whereas it is not seen in the other two. Clear? And the next thing is monitoring. Okay, so monitoring, how you will do? Monitoring of warfarin with prothrombin time, monitoring of unfractionated heparin with PTT, and monitoring of low molecular weight heparin by anti-10A. Okay, so that is important. And the next one, whether it is secreted in breast milk or not. Okay, whether secreted in breast milk or not means yes, warfarin is secreted in breast milk, whereas the other two are not secreted. Clear? Now, generally if you take, the fetal prognosis is good. Okay, sometimes IUGR can occur. Okay, and there can be chances of prematurity because of the risk of preterm labor. Clear? Yes. So, we will discuss some points on peripartum cardiomyopathy also. So, if we take peripartum cardiomyopathy, see, there is cardiac failure in this condition. Okay, and it can occur anytime between 35 weeks of gestational age and up to postpartum period. And in the postpartum period, okay, you have to understand the risk can continue up to 5 months. Okay, so till that we have to be careful. And also remember, these patients will be completely normal during their pregnancy follow-up. Okay, so there will not be any associated cardiac conditions. Okay, and there will not be any cause for heart failure also. Okay, no other cause, no other cardiac conditions or no other cause for cardiac failure, but still they will end up in cardiac failure. Okay, so this is the criteria for diagnosis. And if you see the findings in echo, the ejection fractions will be less than 45%. Okay, and remember, in these patients the mortality rate is up to 10%. Okay, and also some coexisting factor. So, we will see pericardium cardiomyopathy now. So, if we take peripartum cardiomyopathy, see, this is a condition where the patient presents with heart failure. Okay, and this heart failure can start anytime between 35 weeks of gestational age, and it can continue even in the puerperium period. Okay, and the risk in the puerperium period is even up to 5 months. Okay, and remember, the patient will be absolutely normal during her follow-up. Okay, so there will not be any cardiac conditions associated. Okay, her other systems will also be normal. So, no other cause for cardiac failure. Okay. only associated condition that we can see with cardiomyopathy, peripartum cardiomyopathy is PAH, okay, pregnancy induced hypertension. So, during screening there can be increased levels of soluble FMS like tyrosine kinase. Clear? And some consider vasoinhibin as a etiological factor. Okay. The echo in these patients will show a reduced left ventricular ejection fraction, okay, that is less than 45%, and the left ventricular dimensions, okay, will also be reduced. And the mortality in these patients can go up to 10%, and there is also a risk of recurrence in the next pregnancy, and the recurrence risk is around 20%. Okay, and if you see the recovery period, most of the times people will recover within a period of 6 months. Okay, and this will be in 50% of the patients. In some patients, there will be some residual disease left. Okay, some of the residual disease will be left. So, if there are signs of residual disease present, and then this becomes absolute contraindication for the next pregnancy. Okay, and regarding treatment, since vasoinhibin is considered as a etiological factor, we are going to treat them with bromocriptine. Clear? So, with this we are completing our discussion on heart disease and pregnancy. So, until we meet in the next video, take care, happy learning and bye-bye.